My name is Mona Shafey. I'm a hematologist and clinical associate professor at the University of Calgary in Calgary, Alberta, Canada. And today's presentation is entitled Updates on the Treatment of Chronic Lymphocytic Leukemia. The focus of this presentation will be to present updates from the virtual ASCO 2020 meeting. These are my disclosures. Questions that CLL trials are aiming to address include the following. Do second-generation BTK inhibitors have an improved safety profile over standard chemoimmunotherapies? And is the safety profile of these newer BTK inhibitors improved over that of the first-in-class ibrutinib? In addition, fixed-duration therapy is becoming much more attractive, both to patients and providers. And multiple combination therapies are being studied in various settings with the aim of looking at minimal residual disease, or MRD, as an endpoint, and whether or not this correlates with overall survival. The last is whether or not the addition of monoclonal antibodies added to one of these novel agents, venetoclax or BTK inhibitor, improve efficacy, improves the achievement of long-term remissions to justify the added toxicity of adding these agents. Currently, we have both ibrutinib and acalabrutinib available in Canada for both untreated CLL as monotherapy or in combination with obinutuzumab. And for relapsed CLL, it's available as monotherapy. And although ibrutinib is also approved for use in combination with bendamustine rituximab, this is not commonly used. Other indications for ibrutinib include other low-grade lymphomas, including mantle cell, marginal zone, Waldenstrom's, as well as the management of primarily chronic GVHD in allogeneic stem cell transplant patients. Acalabrutinib is limited to mantle cell lymphoma at this time. Zanubrutinib is another novel Bruton kinase inhibitor that has been approved by the FDA for mantle cell lymphoma. For the BCL2 inhibitors, we have venetoclax. It is available both in frontline and in relapse setting in combination with obinutuzumab, and this is currently under PCOR review. Relapsed CLL, it's available as either indefinite monotherapy in patients with either deletion 17p or no other available treatment options, but also in combination with rituximab for a fixed duration of 2 years. The purpose of this presentation is to summarize the clinical trials presented at the virtual ASCO 2020 meeting on the treatment of CLL. In terms of which abstracts were selected, 82 studies that were presented under hematological malignancy, lymphoid, and CLL were reviewed. And the focus is on presentations reporting on efficacy and safety of CLL therapies. Looking at ongoing trials with results in adult patients, limited to prospective trials, a total of 5 studies met the inclusion and exclusion criteria. They are as follows: acalabrutinib in treatment-naive CLL, looking at mature results from a phase 2 study demonstrating durable remissions and long-term tolerability. Acalabrutinib versus idelalisib plus rituximab or bendamustine rituximab in relapse refractory CLL, which is the ASCEND final results. Initial results of the multi-center investigator-initiated study of MRD-driven time-limited therapy with zanubrutinib, obinutuzumab, and venetoclax. Fixed duration venetoclax and obinutuzumab for previously untreated patients with CLL. Follow-up of efficacy and safety results from the CLL-14 trial. And effective adding ublituximab to ibrutinib on progression-free survival, response rates, and MRD negativity in previously treated high-risk CLL, final results of the Genuine phase 3 study. So looking at the first trial, acalabrutinib in the treatment-naive CLL, mature results from the phase 2 study demonstrating durable remissions and long-term tolerability. So the objective of this study was to examine the long-term safety and efficacy of acalabrutinib monotherapy for patients with treatment-naive CLL. In this phase 2 trial, patients received either acalabrutinib 100 milligrams twice a day or 200 milligrams once daily, although a later amendment had all patients receiving the twice daily dosing based on the increased BTK occupancy of the 100 milligram BID dosing. A total of 99 patients were enrolled on the study. And to be enrolled on the study, you had to have either been inappropriate for or had declined standard chemotherapy treatment. The median age of patients in the study was 64, and ECOG performance was 0 to 2. 10% of these patients were noted to have the TP53 mutation, and 62% had unmutated IGHV status. All patients received acalabrutinib until disease progression or unacceptable toxicity. The primary endpoint of the study was safety. Other endpoints examined included investigator-assessed overall response rate, time to response, duration of response, and event-free survival. At a median follow-up of 53 months, 86% of patients remained on treatment. 6 patients did discontinue therapy because of adverse events. 3 patients for progressive disease, one of which was a Richter's transformation. No patients discontinued treatment due to bleeding, hypertension, or atrial fibrillation. The most common AEs of any grade included diarrhea, headache, upper respiratory tract infections, arthralgia, and contusion. When looking at adverse events of clinical interest, atrial fibrillation occurred in only 5% of patients, with these primarily being grade 1 to 2 events. The frequency was about 1% in years 1, 2, and 4, and 3% in year 3. Other notable events include cytopenias, notably neutropenia, although some patients did suffer from grade 3 anemia and thrombocytopenia, as well as major hemorrhage, where the frequency was quite low at 3%. Other adverse events of clinical interest include hypertension, which occurred in all grades, 22% of patients, and grade 3 or more in 11% of patients. Infections, grade 1 to 2, were common at 84%. These are primarily upper respiratory tract infections and sinusitis, with a few opportunistic infections, including a grade 2 fungal infection, grade 2 coccidiomycosis, and grade 2 herpes zoster in 1 patient each. And 1 patient experienced both grade 3 fungal perineal infection and grade 3 herpes zoster. Secondary primary malignancies occurred in 26% of patients. Tumor lysis syndrome was not seen in this patient population. When looking at the treatment-emergent adverse events over time, this did appear to decrease with time, particularly the most frequent side effects, meaning diarrhea and headache. Moving on to efficacy endpoints, the median follow-up at 53 months, the overall response rate was 97% and 100% when limited to the high-risk subgroup populations. The majority of these responses were partial remission. The median time to response was 3.7 months, and the duration of response has not yet been reached. The median event-free survival has also not yet been reached, and with 90% of people remaining event-free at 48 months. The major conclusions of the study include the longest safety and efficacy follow-up for acalabrutinib monotherapy in symptomatic treatment-naive patients. It did not report any new safety signals, which is important as the primary endpoint of the study. The discontinuation rate for AEs was low, and this may explain why the event-free survival appeared superior when comparison to ibrutinib, but the population itself was also different compared to upfront ibrutinib trials. For hypertension and atrial fibrillation, the rates do certainly seem to be lower than those reported for ibrutinib. The most common side effect was headache. These were low grade and were managed symptomatically with conservative therapies. This certainly supports moving forward with acalabrutinib in phase 3 trials with no new safety signals. For the second study, acalabrutinib versus idelalisib plus rituximab or bendamustine plus rituximab in relapsed refractory CLL, the ASCEND final results. These are recruited patients who had relapsed or had refractory CLL and a reasonably good performance status. About 16% of patients had deletion 17p and 78% had unmutated IGHV. The median age of this population was 67. Patients enrolled in the study were randomized 1-to-1 to receive either acalabrutinib 100 milligrams twice a day versus the investigator choice between idelalisib rituximab or bendamustine rituximab. The vast majority of patients, in fact, received the novel treatment with idelalisib plus rituximab rather than repeat chemoimmunotherapy. The primary endpoint of the study was progression-free survival, and secondary endpoints included overall response rate, overall survival, and safety. At a median follow-up of 22 months, the progression-free survival was significantly improved in the acalabrutinib arm, and in fact, the median PFS had not been reached, with a hazard ratio of 0.27 when compared to idelalisib rituximab and 0.29 when compared to bendamustine rituximab. The median PFS for bendamustine rituximab was 18.6 months, and idelalisib rituximab at 16.2 months, on par with previously reported clinical studies. Other efficacy endpoints of note is that at the 18th month mark, 82% of patients remained progression-free on the acalabrutinib arm, whereas more than 50% of patients in the investigator choice arm had relapsed. The overall response rates and survival remain the same between the two groups. When looking at particular subgroups, progression-free survival was significantly prolonged in patients who received acalabrutinib versus the other treatments if they had the deletion 17p mutation, and also significantly improved with the unmutated IGHV status or mutated status. The common adverse effects are listed here in this table, and there are no new safety signals from the study. Again, for acalabrutinib, headache and diarrhea are the most frequent adverse events, with neutropenia grade 1 to 2 occurring in about 21% of patients, and grade 3 at 17%. In comparison, both idelalisib and rituximab and bendamustine rituximab had higher rates of neutropenia, particularly grade 3 neutropenia, with the highest rates of diarrhea in patients receiving idelalisib rituximab. With respect to other adverse events of clinical interest, atrial fibrillation occurred in 6% of patients. Major hemorrhage was 3%. grade 3 or more infections in 20%, and secondary malignancies 5% in patients who received acalabrutinib. With respect to idelalisib rituximab, the rates of atrial fibrillation were 3%, major hemorrhage was 3%, and grade 3 infections or more was 25%. Secondary malignancy was 2%. With respect to discontinuation rates, this was the highest in the idelalisib rituximab arm due to severe adverse events. And with respect to acalabrutinib, the discontinuation rate was 14%, similar to what was seen with bendamustine rituximab. The final results of the ASCEND trial confirm the earlier findings and support the favorable efficacy and safety of acalabrutinib compared to standard care regimens. Again, headaches was the most frequent side effect associated with acalabrutinib, generally of low toxicity and easily managed with conservative therapies, decreasing with time. It's important to note that acalabrutinib had fewer cardiovascular toxicities, as well as less major bleeding and bruising compared to ibrutinib. Moving on to the fixed duration therapy trial, looking at the initial results of multi-center investigator-initiated study of MRD-driven time-limited therapy with zanubrutinib, obinutuzumab, and venetoclax. In this study, the objective was to evaluate the efficacy of time-limited therapy guided by MRD with zanubrutinib, obinutuzumab, and venetoclax for patients with treatment-naive CLL. In this multi-center investigator-initiated trial, these patients with untreated CLL were given this combination in 28-day cycles with an initial 2-month period of zanubrutinib, obinutuzumab alone, and then venetoclax added in the 3rd month with the typical ramp-up period. The treatment duration was based on MRD levels with a minimum of 8 cycles of therapy. MRD was assessed both in the peripheral blood and in the bone marrow, and starting at cycle 1 every 2 months. Once undetectable MRD was established in the peripheral blood, it was then confirmed in the bone marrow, and treatment was then continued for another 2 cycles and then discontinued. The primary endpoint was the frequency of undetectable MRD in the peripheral blood and bone marrow. When looking at the establishment of MRD negativity over time, this was rapidly apparent in the first 6 months of therapy, but did continue to increase with time, and overall nearly 2/3 of patients, or 62%, met the undetectable MRD endpoint and stopped therapy at a median of 8 months, with the time to reach this at about 6 months. Looking at the treatment adverse events, all of the listed adverse events can be attributed to the individual toxicity profile of the individual medications. As an example, the infusion-related reactions was attributed to the obinutuzumab, neutropenia, thrombocytopenia, anemia, predominantly from the venetoclax with combination from the zanubrutinib. Diarrhea being frequent, 41%, commonly attributed to the venetoclax, and bruising being attributed to the BTK inhibitor effect. No new or additional safety signals were identified in the study. Other clinically important safety outcomes with respect to bleeding, this was a 12.8% at any grade. Atrial fibrillation at 2.6%, and hypertension at 5.1%. With the ramp up introduced at month number 3, this reduced the number of patients overall that were at medium and high risk for TLS, and with no laboratory clinical TLS reported in the study. Zanubrutinib, obinutuzumab, and venetoclax is well tolerated and achieves a rapidly undetectable minimal residual disease. This is the first study, in fact, that used MRD guidance to establish an endpoint for therapy. It provided insights into the kinetics and quality of response, and will further help determine the ideal length of treatment in patients who achieve undetectable minimal residual disease. The next study is an update on the CLL14 trial, which is the fixed duration venetoclax obinutuzumab for previously untreated patients with CLL, looking at efficacy and safety results. So this study was modeled on the CLL11 trial, which compared chlamycil with the monoclonal antibody, in particular obinutuzumab, versus chlamycil alone, using a particularly frail population, SIRS greater than 6 or creatinine clearance less than 70 mL per minute. As such, the venetoclax obinutuzumab experimental arm was being compared to the standard chemotherapy arm, chlamycil obinutuzumab. In this study, however, chlamycil is extended for another further cycles to match the 6 additional cycles of venetoclax monotherapy. The primary endpoint of the study was progression-free survival. Secondary endpoints looked at response, minimal residual disease, and overall survival. In this study, the median progression-free survival had not been reached in the experimental arm containing venetoclax obinutuzumab. It was 33.6 months in the chlamycil obinutuzumab, which is quite similar to what was seen in the CLL11 trial. The 3-year progression-free survival was also superior, with 81.9% of patients remaining in remission on the venetoclax obinutuzumab arm, with nearly 50% of patients in the chlamycil obinutuzumab arm already relapsed. The overall survival has not been reached in either of these arms to date. Undetectable minimal residual disease was established in 75.5% of patients quite early in the venetoclax obinutuzumab arm versus 35.2% in chlamycil obinutuzumab. And this was more likely to be persistent in the venetoclax obinutuzumab arm at 18 months post-treatment, with 47.2% of patients still without undetectable MRD. This graph certainly shows superior progression-free survival in patients who are TP53 mutated, not mutated, and this is certainly improved with the use of venetoclax, but this does not overcome completely the inferior survival of P53 mutated patients. IGHV mutated versus unmutated status. There's no difference in outcomes in the venetoclax obinutuzumab arm, but certainly patients who are unmutated who received chemoimmunotherapy had inferior outcomes. With respect to some safety endpoints, there were no new safety signals observed with the venetoclax obinutuzumab. The rates of secondary primary malignancy were high in both groups, which is a reflection of this older age, more frail population, occurring in 17% of the venetoclax and inotuzumab arm and 10.3% in the crimesolve and inotuzumab arm. The results of this study clearly showed that venetoclax and inotuzumab is a very effective regimen in the treatment of CLL with significantly prolonged progression-free survival and deeper remissions noted through higher rates of undetectable MRD, regardless of risk factors, including TP53 and unmutated IGHV status. These data certainly support deep and durable remissions, even with the fixed duration approach. Lastly, the effect of adding ublituximab to ibrutinib was assessed for progression-free survival, response rate, and MRD negativity in previously treated high-risk CLL. This is a phase 3 study looking at the addition of monoclonal antibody to improve efficacy. Other studies using rituximab or obinutuzumab in addition to ibrutinib to date have not shown any impact on progression-free and overall survival. In this study, patients with relapsed refractory CLL were randomized to receive either ibrutinib or ibrutinib in combination with ublituximab. They received this monthly for the first 6 cycles, and then every 3 months thereafter. With respect to response rates, the overall response rate was 93%, and complete responses were 20% in the combination arm versus 78% and 5% with the ibrutinib monotherapy, respectively. Progression-free survival was significantly prolonged in patients receiving rituximab in addition to ibrutinib, and the median has not yet been reported, versus a median PFS of 35.9 months for ibrutinib. Undetectable MRD was also significantly higher in patients who received combination ibrutinib with the monoclonal antibody. With respect to the most common adverse events, no new safety signals were reported. Important findings include infusional reactions, which is not surprising, significantly higher in patients with ublituximab, but only 3% of these were considered grade 3 or 4. Neutropenia of all grades was also higher in the combination arm. This is the first randomized trial demonstrating a progression-free survival benefit using a monoclonal antibody in addition to ibrutinib, increasing the depth of response after the first year of treatment, and may support the use of maintenance therapy in combination with the ibrutinib. Further data is obviously needed to look at overall survival benefit and any long-term toxicity with this combination. Thus, going back to our original questions that we started at the beginning of this presentation, do second-generation BTK inhibitors have an improved safety profile over standard chemotherapies? And is the safety profile of newer BTK inhibitors improved over that of ibrutinib? So far, the data from the acalabrutinib studies do suggest a favorable side effect profile, in particular when it comes to cardiovascular toxicity. It does have its own unique side effect profile with the common complaint of headaches, but these are generally mild, treated with conservative management, and often disappear within the first few months of treatment. And to date, the both the frontline treatment as well as the ASCEND trial in the relapse setting show the efficacy to be very favorable as compared to standard chemotherapy regimens and or other alternative novel treatments such as cetuximab, and certainly comparable efficacy to ibrutinib. With respect to fixed duration treatment, at this point, the use of MRD as a clinical endpoint and in clinical practice is still an ongoing question. The ideal treatment for a patient with CLL should be one that is effective, that can be administered as a fixed duration and have long-term efficacy, and allow one for discontinuation to reduce the toxicity. This combination of zanubrutinib, obinutuzumab, venetoclax is certainly an efficacious regimen that results in rapidly undetectable MRD, with the average patient who achieves this receiving 8 months of therapy, which is very attractive for patients who wish to have a defined period of treatment. This obviously comes at a cost of increased toxicity, at least in the short term, and further study will certainly be needed to identify which combination and for how long, and using what measures to decide what's the ideal management of a particular CLL patient. This last study, the Genuine study, is a first to show a monoclonal antibody addition to ibrutinib improving efficacy with longer progression-free survival, which certainly suggests moving forward with this monoclonal antibody and further study to improve other outcomes.